not working actually, retired in the UK. And great pleasure to chair this teleclass this afternoon. It's a good friend of mine who's going to be speaking. And we're talking to retired Professor of Infection Prevention, Shaheen Mehtar, who worked at Tygerberg Hospital and Stellenbosch University in Cape Town. Originally, though, I came across her when she was working as a medical microbiologist in the UK, heading up the microbiology department at North Middlesex Hospital. She's also been an honorary senior lecturer at the Royal Free Hospital there. Now, she's set up several infection control societies globally, apart from setting up the unit in South Africa, in the hospital she worked in. But she founded and chaired the Infection Control Africa Network, ICAN, which is the largest IPC organization in Africa, which covers the entire continent, concentrating on education and leadership. She also established several postgraduate IPC courses for Africa and Belong. She's served on many international societies, such as the Healthcare Infection Society in the UK, the British Society of Antimicrobial Chemotherapy, and the International Society of Infectious Diseases. She's been a long-term member of the World Health Organization guideline development groups and the CDC consultative organisms since the early 1990s. She's also worked in several refugee camps and displaced person establishments. She's published extensively, as you would imagine, in peer-reviewed journals, as well as written several books and chapters. And I would have to say Shaheen is possibly the most persuasive person I've ever come across. It's almost impossible to say no to her. So looking forward to this teleclass called Implementing Infection Prevention and Control, a Global Challenge. Welcome, Shaheen.
Thank you very much. Shall I turn my video off, or shall I disable the camera?
No, you're fine this way you are.
Okay, right. So good morning, good afternoon, good evening, everybody. I'm going to talk to you about something which we've been talking about since infection control, the inception of infection control, and that is implementing infection control. So is this a global problem? Or is this a problem in low resource settings? Or is this a problem in high resource settings? And each one of us seem to think that the problem is theirs because that's what we all face. So I'd like to, if you like, deconstruct some of the areas around implementation in a slightly different way to what most of us do, and see if we can come up with some ideas about what's going on. And then towards the end of it, I'll present a little bit of my personal experience of setting up infection control in the Tygerberg Hospital where I was working. I'd like this thing to move now. Okay, it's not moving. Oh, sorry. Okay, I've gone too far, so apologies. Right, let's try again. There we are. So what I'd like to do is to identify some of these areas, and then looking at the main thing, which seems to be a challenge, is the cost of HAI, and certainly for low to middle income countries, and whether they have understood the concept of cost benefit of infection prevention. Trying to look at some of the strategies, if possible, to overcome these barriers. And we know that every single organization that is linked to infection prevention will talk about strategies, because that is something that people talk about. Whether it gets implemented is another matter. And of course, moving forward, we want to see what's happening with the cultural norms. So there's no shortage of guidelines, as we all know. And for those of you who have been in this world and wide awake would understand that every single 6 months for the last 20 years, we have had a guideline linked to infection prevention. There have been minimum requirements, there have been global problems, there have been components, all sorts of goodies have been going on. And this is not only in one area, because there's been a great push for national organizations to be, national societies and national countries to be looking at setting up. And so South Africa being no different, there's the National Strategic Framework that we set up in 2020, which I had the great honor of chairing, and a practical manual that goes with it, again, with the word of implementation stuck in there. And then we've got the Namibians, which is just one of the new documents that they've produced, but there are many others in Africa. So we would imagine that are probably about, or most of the African countries would have national guidelines. So what does this mean in real terms, and where is this going? So why is there a problem with implementation? Is it because we don't have enough infrastructure? Or is it because there's a lack of available funds? And I'm not just referring to low income settings, I'm talking about high income settings as well. Is there lack of political will? Is there complacency? Is there information fatigue? As my good friend Prof. Sito from Hong Kong frequently talks about for hand hygiene, or is it all of the above? I personally think that we need to look about what's happening in the in the low-income countries, and their financial constraints is the main area. That this is because there's a lot of donor dependence, and if those of you that were around in the last 6 to 8 months would have recognized the fact that vast amount of money was withdrawn from Africa in particular, which was paying for via the PEPFAR scheme, was paying for the HIV program. Leaving millions of people. There are 10 million people, as you know, in South Africa with HIV, and leaving many of them destitute. We were lucky that we had an organized national health system that could actually help. However, in many countries, their entire health budget was removed, and that was a problem. The next one would be, of course, looking at the weak leadership and accountability. They have national health systems in place, certainly for when they do the WHO evaluations, but the health service level is fragmented, or it could be the other way around. There's a lack of infrastructure, particularly water, sanitation, hygiene, major issues happening across the globe, not only just in low income, but also in high resource settings. And there's resource constraints where physically there isn't the space to deliver health in an appropriate manner. There's a problem with PPP, as we all remember, PPE rather. During COVID, there was a ban on export of protective equipment from various parts of the world, and so some of the other countries had to suffer, like South Africa didn't have, and many other countries ran out as well. There's a shortage of infection control staff, and I realize this because we run certain very, very high level courses in infection prevention. There's a postgraduate diploma, there's a master's, and so on. And once we've trained them, they go. If they do stay, there is a problem because they're not being used as they should be used. They're not used as infection control practitioners. They're used as general staff. And of course, I'll show you some of the data that we collected looking at what's happening with the administrative and the surveillance aspects of an infection control practitioner, and time for clinical practice. The training of them is also quite interesting because it can be set to a very high standard, or it could be set to whatever way the particular aspect is dictated. In other words, anybody can come along and train, as we noticed during COVID. The problem that we do come across is that the guidelines are not contextually appropriate. So they are cut and pasted from a high-income country, from CDC, from the United Kingdom, from this guideline and that guideline, but they may not work in the countries that have actually used them or incorporated them. And the reason they don't work is because there isn't the background and the infrastructure that allows them to go forward with this. And that in itself causes a big problem, particularly since many of these countries don't have their own data and the surveillance systems are not very good. And these need to be set up. And one of the reasons I'm talking to you about this and deconstructing infection prevention and its elements is to make sure that one understands what goes into this rather than just a big barrel of information that can be chucked around. Cultural barriers exist all over. There's resistance to change, which we will address. There are infection, IPC operates in silos. There's no integration in some places. And sometimes they're not invited or they're not accepted by certain other departments, thinking that they are probably not in the same level as themselves. And of course, there's weak quality management and the lack of that, of monitoring. Sorry, I keep... I think I overdid this. Sorry. Right. So this is the impact of the financial constraint. So as I've just mentioned, I just want to go through this very, very, very briefly, saying that it affects a vast amount of areas that we require for infection prevention. In high-income countries, the financial capacity may be good, but effective infection control programs will depend upon the allocation of these funds and the budgets and where the money goes and who's prioritized. And so if infection control is considered a cost and not a strategic investment, then obviously the finances towards it is very little. And this is a big issue also in low to middle income countries, because if they're going to take money away from something, they will take it away from infection prevention or indeed not even put it into the budget. In high-income countries, it's a slightly different issue. They're looking at behavioral and cultural issues because there's compliance matters, a lack of compliance with the infection control policies. There's complacency because they've got their buddies in infection control looking after everything. Hierarchical control is to prevent the modification of practice. And I mean, I've been doing this for the last 50 years, and I don't expect you to stop me doing it any longer. Infection control is not prioritized. We know this. And the cost of HAIs is never, ever advertised widely enough for people to understand it. And I think this is one of the big problems we have as practitioners. We don't tell people what they're costing as healthcare workers regarding patient life and also to the facilities themselves. It is not represented on infection control or on AMS teams some places. Thankfully, the ones in South Africa are. They're required to be there, but the other countries may not. There's a lack of continuous training. There are big communication gaps, so there's mixed messages all the time. And particularly if there's an outbreak, or if there's a pandemic, or if there's something that is going to require concentrated infection control information, the messages become mixed. And this has been clearly seen during COVID. The obviously, again, they're working in silos. It's a complex health system. There are care homes. There are people outside in the community that also interact very closely with the inpatient population. And these have got to be looked at and managed, but there are communication gaps there, as they are with data and surveillance, underreporting a lot, and they don't understand. Patients may not understand, and they don't follow what you're telling them to do. And most importantly, there's technological fatigue. There's multiple electronic systems. You spend more time entering data about whatever's going on, and this really overwhelms the staff and doesn't allow them to do their jobs properly. The one thing that is a big problem is the infrastructure, but I just want to show you this 2024 report, which is quite encouraging, I must say. And here I'm going to actually open up my screen a bit more. That's much better. I can see it now. So here we're looking at the access to water increasing from 13 to 18, as they say here. They go from soap availability, which is obviously the big push for hand hygiene, looking at soap in households to 76%, and sanitation going up to 40%. Now that is good stuff. A report written by WASH in 2023 clearly looked at the various aspects and the benefits of carrying out achieving the WASH requirements and the IPC practices, and they recommend, or they suggest, that the return on investment is 15 times higher. I just want you to look at this figure here, which has also been put out there, which says that initially there will be an increase in capital expenditure, which is the deep purple one. But as we go on in years, we hope that by 2030, the operation and maintenance cost will be much higher than the capital expenditure. Now, this in itself is a problem, because in most of the low to middle income countries and countries that I've had the privilege of working in, they don't have the money for operation and maintenance. Somebody comes along and donates capital expenditure, something that goes into a system. There could be sterilizers, there could be bathrooms, whatever they put into place. And then once they've gone, there's no funds available for the operational side of it. So here again, if we deconstruct this and we look at this, we want to consider whether in fact this is the right way to go about, and whether there is going to be a possibility that anybody will find funding for operation and maintenance after the capital equipment has been purchased. I think all of you might have seen this document. If you haven't seen this document, please do go and have a look at it. It's a really good paper looking at, published in the Lancet, looking at the various income groups, which is the World Bank income levels, how they are complying with the core component. So the first core component, as you all know, is of course the infection control program. And what I want to show you here, which I've highlighted, which I hope you can see, is that a protected and dedicated budget in infection control is only 41% of the globe. 70% of that is in high-income countries and 15% in low-income countries. So therein lies the rub. There is the problem. There isn't the money. It's not that they don't have money. There isn't the money to be able to do this. The second aspect is the guidelines. Everybody's got guidelines because they cut and paste from each other. They can download it from the internet. Chat GPT will do it for you. Whatever you want will be happening around you. But these have to be revised and updated every 5 years, which is not usually happening. And finally, you're looking in the, sorry, not finally, but the third core component that you're looking at over here is the education and training. And their national curriculums have been developed and they are being dealt with. So what it says to me anyway, is that, look, we have got the policies, we have got the education, but we haven't got the budget to run these things, which in itself doesn't make sense, because if there's been any investment in the first two, then the latter should really be looked after. And then, of course, there's the issue of surveillance. As you can see here, across the board, there's a big problem with surveillance, trying to get it up and running, trying to get it moving. And that's been one of the big pushes we've had from ICANN to try and see what we can do in that regard. Because without this data, we really can't function. The other two core components, which is multimodal strategies, it works. I mean, there are many countries that have set it up. They're trying to get it promoted. They're very similar between high and low income countries. But the problem here seems to be that they don't really understand what it is. And I think this is where, again, you have to get them to open up and to deconstruct infection control, to understand what these multimodal strategies actually mean. You know, it's not just me, myself, sitting in my office with a piece of paper. You've got to go out there and talk to many, many people and get involved with each other and their work practices, so the silos are broken down. And of course, the monitoring and evaluation, as you can see, these multidisciplinary technical teams are required, and those are in place. How functioning they are is another matter. Strategic planning goes ahead. There's a minimal set of core indicators and so on, and hand hygiene compliance, which goes up and down. So I think within these, the main focus, again, is the finances of what's going on. And if we compare the cost of implementing the WHO core components, all 8 of them, it's interesting to see the difference between the two parts of the world, so of the low and the high income countries. So if you're trying to implement or setting up an IPC program, it's less expensive in a low income setting than it is in a high income setting, obviously, because of salaries, because of structures required, and I'll go into that in a minute. Guidelines, again, is not difficult because you cut and paste, whereas on the high-income side, you have societies and prestigious organizations of knowledgeable experts who will sit together and they will write guidelines which are very evidence-based. So that is good and not expensive. Education and training is a bit expensive in low-end resource settings, and possibly also in high, obviously, because there's the cost of running the courses. Surveillance is a big problem, and that is about the relative cost, which is middle sort of range if you're doing it manually. However, if you're doing surveillance in a high resource setting, it's going to be much more expensive because they do it electronically. Multimodal strategies is the same. Monitoring and feedback are very similar. Staff and bed occupancy and workload, again, now you're looking at people coming into work, you're offering jobs, you're opening up opportunities, and you're trying to get people engaged in doing not only infection prevention directly as nurse practitioners, but also around and surrounding them in WASH and so on and so forth. So that starts becoming expensive because of the manpower and also because of the structures. And of course, ultimately the built environment, which is expensive. So if one is looking at this, if you could start at the beginning and work your way up, there's no way that you're going to make it up to the core component 8 in a short period of time. And this was the study that came out from the WHO for 2021, that there were only 4 countries out of 106 that were analyzed or that reported, the only 4 countries could do 100%. 45% would do 75% of the core components or the minimum requirement, and 81 could do 75% of it, 50%. So now the problem comes back to what's going on here. Why is it that the minimum requirements are so difficult to do? What is going on? And so it is because they can meet the indicator, but they can't do it. And again, we come back to this problem about deconstructing what we're doing, how we're doing it, and whether we can reach these core components that we've just discussed. And I think there's a big problem here because the expectation is far higher than what one can deliver. And we all need to think that through. And this, of course, reflects quite clearly in the data that is available on HAI, healthcare-associated infections, where overall the prevalence in one part of the world, in the high-income countries, is up to 7%, whereas in the low-resource settings is up to 15%. Surgical site infections go from 5 highest to 30. Catheter-associated infections go from 5 to 15. And ventilator-associated pneumonias go up to 30% in lower resource settings, 15% in high resource settings, and then bloodstream infections can go up to 15%. Now, this tells me something. And what this tells me is that it's not so much the fact that we don't know what we're doing. It's just that we haven't got the resources to make sure that the surrounding structures, such as sterile catheters, and I'll show you a study that was done in pediatrics, and ventilators and so on, and looking at the infrastructure that supports this. So if we look at the breakdown, the average cost, surgical site infections in high-income countries about 20,000, in low resource settings is 1,000. You want to wonder why, and I do. Why is there such a big difference in these costs? The bloodstream infections, 25,000 in a high resource setting, and 1,200 in a low resource setting. Pneumonia goes from 18 to 900, and urinary tract infections from 10,000 to 500. And is this because of the way we deal with the healthcare associated infection? Is it the support that is provided to somebody who has an HAI, or is it because the low resource setting doesn't have anything to support it when it's dealing with that? And therefore, if you're looking at an average cost between a high and a low resource setting, you're going from 15,000 is the cost that has been estimated from the United States to 800, which is a cost that has been looked at one of the countries in Africa. That is a phenomenal amount of money, a difference in what is going on. And therefore, does one look and consider that the expectations are different? Are we thinking of something else? I don't want to go into the great detail of this and don't want to delve in it, but if you go from personnel right the way down to technical assistance in a low resource setting, you could set up an infection control program for 500,000 or maximum 1.4 million. Okay, this is just taking you through what's going on, and you can look at it in your own time. However, if you look at the cost, this was estimated, the national cost for HAIs is $4.6 billion US dollars. And this is about 1.1% of the gross domestic product. It is about 5% of the health budget. Can't afford it, I can assure you. And hospital level, it is 0.37 million. And of course, there's several millions per hospital. And the reason I want to show you this is that we have got the costing and we know what we're looking at, but we're not applying it and we're not thinking it through. So if we were then to provide an infection control service per bed, okay, we would be looking at, for a high-income country, somewhere in the region of $4,250, whereas in the low-income country, it'd be $470. It's not bad. It's 11 times more expensive. And we know why that is, because we've just seen what that was about. So if you're looking at I would like to look at the cost of an HAI versus an IPC specialist cost. Okay, so looking at the HAI from low resource settings in the WHO report, the average cost would be 1,200 to 5,000, and you're looking at a rate of about 15%. So the estimated annual cost would be about 10 billion US dollars, which is conservative. The salary of an IPC practitioner would be 8,500, or if it's a doctor practitioner, it would be 17,500. So even one tenth of an HAI cost could fund up to 100,000 IPC practitioners. Okay, and the total estimated need for IPC staff across low resource settings is much less than this. But of course, it tells us, and I think I'm preaching to the converted here, but it is really important to look at this data and to realize how cost effective infection control really is, and that we should push strongly to advocate for better infection control involvement. The saving that can be realized from the Lancet paper that was published was looking at a reduction of 30 to 50% of the cost-benefit ratio of 2 to 1 to 6 to 1, whereas in high-income countries, you could save between 2 to 4 for every dollar spent. In low-income countries, there's twice that. You can look up to $6 for every dollar spent. And the reason this is more important in a low-resource setting is because the money is short. as I pointed out right in the beginning. If you're doing hand hygiene, you can reduce 40% of the infection, which is incredible. If you can just look at just one aspect of what's going on. Okay, this is a very nice diagrammatic representation of the One Health program, looking at everything, the impact on mortality in the top left-hand corner, the economic impact in the top right-hand corner, and the two main things here, which are very much within our remit and our ambit, are environmental hygiene and hand hygiene. That includes, for the first two, resistant and susceptible infections, and thereon it goes on to looking at the resistant infection like antimicrobial stewardship and so on. And I don't want you to concentrate on those. I just want you to look at the fact that if we just, without any money available to us, looked at these two aspects, we would be looking at, for every dollar invested in environmental hygiene, you'd save 5. But if you invested $1 to improve hand hygiene, you would actually get about $25 back. So I think every low to middle resource setting countries, and indeed high resource setting countries, should look at this and consider very carefully about how they're going to do what they're going to do. This is a paper which I found really interesting. It was published by a group of people, pediatricians from, including my hospital, Professor Mark Cotton, but people from Brazil and from high resource settings as well. And they looked at and compared antimicrobial stewardship and infection prevention available as resources across this sort of barrier. Okay, so the antimicrobial stewardship programs in low resource and high resource settings were slightly different. There were formally included, and this is really looking at pediatrics in the main, but there we go. It was formally includes pediatric patients, and some were adult focused. Some of them, they didn't know what was going on, and of course some of them didn't have it. So really it's just the green ones you need to concentrate on for low resource settings, which is about under 40%. For high resource settings, you're looking at about 64%. If you looked at the infection control, that was slightly better. And here we're looking at about 45% of them had it, whereas in the high resource settings, you're looking at almost 80%. The personnel that were involved with AMS in high resource settings, the pharmacist, the physician, the adult physician, the general pharmacist were mainly involved. In low resource settings, it was mainly the general pediatrician, the microbiologist, and the IPC practitioner. So that actually tells me that the antimicrobial stewardship program is being driven not by those that are prescribing, but those that are supporting a reduction in infection rates. In other words, trying to make sure that it becomes part of the antimicrobial stewardship, controlling it and trying to bring it better, make it better. The infection control personnel, practitioners, were obviously more in high resource settings, which is the blue line you see here. Pediatric infectious physicians, infectious diseases physicians were involved in IPC. Adult physicians were also involved. General pediatricians were also involved, but microbiologists were involved in the high income settings, and epidemiologists were involved as well. So the only place that in fact infection control sat in low resource settings mainly was with the IPC practitioner, I presume a nurse practitioner, and occasionally those medical people or those clinicians, pediatricians who were actually interested in looking at infection prevention. And that means that there wasn't any real structure as we see in the UK or United States or in Canada, where there's a real structure that talks to you. In low resource settings, there isn't a structure. It is really, going by the seat of your pants, just flying into doing whatever you have to do. Antimicrobial guidelines for empiric therapy, sepsis, neonatal, and surgical prophylaxis existed in all these places, in all these countries, which is rather good to see. But the point of care intervention, again, it was slightly better in high resource settings, but the de-escalation, setting duration, review of antibiotics, and dosage optimization was more or less similar between the two lots. Antibiotic availability, on the other hand, was different in that there's a far better availability, both broad spectrum and intravenous, in high resource settings, as one would imagine. Okay, so the thing that that concerns is that if we have this, much of this was to do with prescribing antibiotics for the kids, and of course looking at how we were going to use this and the de-escalation and so on. But the availability of the antibiotics was again a problem that had to be contended with. Of great interest to me was this particular graph that they produced, which is looking at the intervention. So IPC, interventions for children, is the first one, where hand hygiene was promoted, PPE was available, they managed infection outbreaks, they did hand hygiene audits, slightly better in low resource settings, I see. Surveillance of HAIs, okay. Surveillance of resistance pathogens or infections, and then vaccination during outbreaks and vaccinations during pre-employment. So this is what the interventions were. And they were quite at par between the high and the low resource settings of this particular study. Not too bad. Then access to IPC, and that is looking at sinks near patient beds, which, as you know, now has been moved outside patient areas, but we won't go into that at the moment. But here we've got slightly less availability. Antiseptic hand rub, alcohol-based hand rub, looking at that. Reliable water supply, again, not as good as. Full PPE as required. Okay, disposable gloves, daily cleaning in the patient areas, and boxes of used sharps near blood taking. Okay, so this was more or less balanced, the first two. What was really interesting to me, which would reflect back on the high rates of HAIs in low resource settings, is C, the one at the end, where you are reusing oxygen masks. Okay, you can probably clean them very thoroughly and do that. Nasal prongs, I'm afraid you can't clean very well. PPE, which is being reused, going from patient to patient. Endotracheal tubes going from patient to patient, not a good idea. Nasogastric tubes being reused, and syringes, which I thought in this day and age was an absolutely not a no-no forever, but obviously used. I know that in some countries I've visited, the syringes are used for injections, and then they're washed and cleaned, and then they're used for nasogastric feeds and so on. But nonetheless, there is a very large number of reuse of equipment, which could very well reflect the resistance and also the transmission of pathogens, which is very important to look at. Looking at microbiology services, the resources available, there were 80 low resource setting environment and 43 from high resource setting. And basically, I mean, they used the laboratories, but the notification from positive cultures was very, very retarded. Not at all as one saw in high resource settings, where they were given within 24 hours or they were given within 48 hours. Antibiotic susceptibility testing was not always available, and the reason was because they just didn't have the facilities to do that. And of course, the cascading reporting was okay, it wasn't very good either, and there was periodic updates of the local algorithms, were not so well done in the low resource settings. So the use of the microbiology laboratories were not all that fantastic. Let's just come into this. This is something that is looking at high and low resource settings, where behavioral and cultural resistance to compliance with IPC. And they're not necessarily the same ones. They may be different, or they could be the same, but they are treated in a different way. And these are aspects such as threat, there's professional autonomy, there's role boundaries, you're looking at social and peer norms, you're looking at behavior, workflow, and hierarchical institutions. And let's just go through some of these again. So if you're looking at cultural and behavioral resistance, this is what the published papers, the published literature talks about. And I'm sure you have your own ideas as well, since most of you probably work in a clinical environment. So if you have the perceived risk from infection, in high-income countries, there's a low perceived risk because they have very much better infrastructure and they have lower HAI rates, as shown to them by the practitioners, IPC practitioners. In low resource settings, there's a high awareness of risk, but often it's normalized because the levels of infections are higher, and there's a greater endemicity. So there is a problem there that has to be conceived. So the perceived risk is there, but really not taken too seriously. Professional autonomy, physicians will resist guidelines that because they feel it imposes is unnecessary. And in low resource settings, the guidelines sometimes are bypassed and authority-based hierarchy dominates, and they will tell you what to do. And it's not quite the same as looking at your peers setting up guidelines that you want to follow, as one does in most of the other parts of the world. Workplace culture shows fragmented infection control ownership with high reliance on the team. So it's not my problem, it's her problem or his problem. It's not my problem, ask the IPC practitioner to look at it. And of course, in low resource setting, there's a collective compliance, but it may be undermined because there's it's very weak institutional support. So, you know it, but you can't do much about it. And hierarchies, again, hierarchy with resistance from senior staff that we all know and all have understood and seen. Junior staff are reluctant to challenge them, and so they all carry on in the same way. Whereas in high-end resource settings, I have come across this so much, and it's such a big problem, where there is a solid, very strong medical hierarchy, and nurses will not actually stand up to them. And one of the course of the postgraduate diploma that we run, one of them is about building up the confidence of the IPC practitioners to go and say to them, "I'm terribly sorry, but you've made a mistake, or this is wrong, or we can't have you doing this." And it's not considered rude. It's not considered bad manners if you do it properly. But it is really important to break through these hierarchies. And I have had personal experience of being taken to the CCMA, which is the court for behaving badly, I suppose, for lack of a better term, where I said at a meeting, at a prize giving, that those that had just learned, which happened to be CSSD managers, now know more than the people that run them. And they took great homage to this, and they took me to the commission to say, you can't say things like that in public, even though it was true. So the other thing is called habits and convenience. It's non-compliance due to minor disruptions in the workflow. But basic IPC in a low resource setting is considered impractical, and it's resource intensive, which it's not, but they do see it like that. Again, you're looking at the protocols not being followed properly in the resource context. And of course, in low resource settings, there's a lack of this facility availability. Now, training and motivation in high resource it is perceived to be repetitive or irrelevant. I'm sure Martin will have something to say about this. But it is repetitive, and it is, I don't know about the irrelevant part, but it is repetitive. And I can assure you that, for the people teaching hand hygiene, after you've done it for 1,000 times, the 1,001st time is boring. And so it is repetitive, and there is a lot going on. And obviously we haven't learned yet how to teach properly. And maybe that is something we need to think of as trainers and academics. So the low resource setting, there is another issue. It's not only the fact that it is irregular and top down, but the one thing that we picked up and we've got record of is that during COVID, there were more people being trained by untrained staff than there were being trained by people that understood IPC and were actually trained to train. So in other words, anybody, and this was also true during the Ebola outbreak in Sierra Leone where I was, that we had third-year medical students from America coming with a piece of paper, talking to healthcare workers who'd been doing this in Sierra Leone for the past 25 years, telling them what to do. Okay, so in other words, there were completely untrained people trying to tell you what to do, and it mixes the messages, and it makes a big mess of everything that's happening. The feedback is that there's non-punitive systems are in existence, but they're often not used enough. Whereas in low to middle countries, there is a lot of punitive action, and is discouraging and discourages reporting or initiative because, you don't want to hear about what happened. You get fired or something else will happen. Peer influence is very strong in high resource settings, and I'm glad it is because it can be used. It's a double-edged sword. Either they will comply. If the leaders will comply, the staff will comply. And I think it's really a place that we can start to get people on our side to make sure that this influence. In low resource settings, the senior staff dominate. So even if they've been sticking their finger up their nose before they touch a wound, that's the way it's going to carry on. And there is nothing you can do about stopping it. So you have to think this through very carefully when you are dealing with these behavior changes. Attitude, of course, the IPC fatigue, as I mentioned, skepticism towards the updates. And of course, in the low resource setting, it's slightly different. There's a high dependency on the external partners, and there's local, and because of that, there's very little local ownership. And it's also partly the fault of these organizations that come in because they have a lot of money made available to them. Usually in the global north, money is given to an institution there to deliver health or deliver IPC to an institution in the low resource setting. So the money stays in that part of the world, and what comes across is probably 5 cents in a dollar. And I think that is where the ownership changes matters as well. So now, at national level, we've got international pressure, which is all the wonderful guidelines from WHO, Africa CDC, etc., etc. And also, you've got guidelines coming out of NICE about HIS, SHEA. Everybody's writing guidelines. Fantastic. The pressure from within is what we can do. And what I suggest is that we set up pressure groups where you set up a society, an organization, which is a network of like-minded people, which we have, which is called FIDSA, which is the Federation of Infectious Diseases Societies of Southern Africa. There's 7 societies there. And we sit together with our peers and mentorship programs and exchange data and set up seminars and conferences, a bit like the ICANN conference, where it was amazing to see how many people from all over had come and put pressure. And it becomes a pressure group because you can now start talking to various aspects and various people in the government, if possible. If those of you that had the benefit or the great honor of serving on ministry advisory committees, you know how much influence you can come to bear on. And it's really quite important. You can write contextually grounded evidence-based guidelines. Keep it very, very simple. And I'll show you an example later on of one that I wrote, which I got so fed up of everybody talking. So I just did this one. You can examine the WHO surveys for your own country and see whether it's helping at all year after year. Are you doing anything? We get the JEE, which is the evaluation. And of course, every time it comes through, everybody starts jumping up and down, gets very upset, and then they forget about it. You concentrate on knowledge exchange. It's very, very important. Martin will tell you about it. Paul will tell you about it. The whole point about having something like Weber training is this knowledge exchange. The conversations that we have, the talks that we have, the seminars, the education. I do it this way, you do it that way. Is that good? Is mine good? Are we both right? Showing the cost effectiveness of infection control. I said this ad infinitum, and bringing it to the attention of the government, looking for research funding to support further development, and of course, consider looking at the core components, which are considered low-hanging fruit. But I can tell you some of those are really difficult for some parts of the world. This was the example of a hand hygiene policy. I got so fed up of everybody jumping up and down. This was stuck on the door of my intensive care unit at the North Middlesex Hospital. This is way before anybody had come up with wonderful ideas of how to do this and this global challenge and that global challenge, all before all that. And basically it said no entry, or entry was restricted. And the hand hygiene policy said, hand hygiene disinfection policy. Please decontaminate your hands before and after each patient contact. End of. And that was it. And that was stuck on the board or on the wall or on the door in 1978. If you're dealing with barriers at a facility level, you set up the IPC team. Usually they're not full-time, but anyway, you can try and do that. You convince the CEO, and I was very, very fortunate to work with an amazing CEO at Tygerberg Hospital, showing them the cost of it. And I'll show you what work we did in a minute. Setting up IPC to look at AMS and WASH now, which is what we're doing. We're conducting surveillance is important. The GPPS program is what we're using in some of the parts, and it really helps because it's free. And it gives you the data that you need, and it helps you to move forward a bit until you set up your own systems, of course. Discussions with your clinical colleagues, whether it's formal or informal, give them their rates, talk to them, see how you can help them. Work with the engineers and the staff, please. They are the most important people. The cleaners, the engineers, and the people working around you are very important. And as the head of the IPC unit at Tygerberg, we used to have a quarterly tea party for them. They all came along, and we used to sit and talk and chat about various things over cake and coffee. But one thing that it did lead to was that we never ever had a single bedpan washer not functioning. They put it on the emergency list. So immediately a bedpan washer went down, they would be there to look after it. an autoclave went down, they'd be there to look after it. So it really works well, if you work together. You start introducing multimodal strategies, and of course, you need to get your information published. There is a big problem in low-middle countries. They don't publish. I don't know what the reason is, but they just don't publish. And therefore, there's no data to be used, as it were. All right, so the barriers that we're looking at is that looking at complacency, we're looking at case studies. Professionally, we have to involve the clinicians. We talked about this. The workflow, you can use tools. The high-income resource settings would have electronic ones. We'd probably have paper ones. Introduce a non-punitive peer audits, if possible, through committees. Talk to people individually as well. You can talk to people individually. There's nothing stopping you doing that. Train, incentivize the clinical leaders. And of course, you need to keep changing, prioritize micro changes now and then, just to make things more interesting. And of course, where possible, you can show posters and behavioral nudges, which I'll talk to you about in a while. The other thing is that, of course, you're going to, in low resource settings, you have to try with no cost behavior first. So that's the hand hygiene, the environmental clean. You can deal with these. And we know that they will give us very, very good returns. Reduce glove usage. I'll talk to you about that as well. The confusion of roles is the worst thing that I've come across in such an environment. Everybody is a champion of infection prevention, and they talk all sorts of stuff. So it really is important that we clarify these roles by written instruction, mentorship at regular ward rounds. And if you've got link nurses like we do, then you need to set up and make sure that they understand what's going on as well. You provide on-the-job coaching if you can't get the people out of the wards, and where possible, please talk to the cleaners and obviously everybody else around, including the link nurses. Top-down instruction, you've got to include the junior and the senior staff solving problems together. And whenever we had an outbreak, we'd make sure that we all sit around the table at least once a day till we got to the point where we could move forward. Create feedback loops. I mean, we've got all these WhatsApp groups. I'm on about 17 WhatsApp groups from all over the world. They keep writing to each other, putting me on there, and they talk to each other. And I just stand back. I don't do anything till somebody specifically says, Prof. Mehtar, could you tell us? And then I might say something. Otherwise, if it's going amongst themselves, this peer feed is an amazing, amazing way of learning. It's really phenomenal. And I see it all the time, and I really appreciate it. Everything they have learned, they put into that WhatsApp group, and it's fantastic. So if there's fear of blame or punishment, you have to make sure that has got to go away to a non-punitive system, and where possible, use boards to display information and so on. So I think we've looked at this already, and we have talked about being able to appoint 100,000. But there's a study that was done by Angela Dramowski as part of a PhD, which she looked at the pediatric unit at Tigerberg Hospital with an outbreak. And at the cost of infection she looked at was the direct cost was 371,000. This was just in one ward, in one unit. And the additional days was 2,275, looking at 2,365 microbial days and lots of laboratory tests. So it's very important that we understand what's going on. And if there's any way that we could put this effectiveness out there, because it is important that the societies drive the IPC agenda, and you act as a pressure group to enforce infection control. She has gone ahead and set up a wonderful program now across Africa, including 7 to 10 other countries, looking at infection control and reducing healthcare-associated infections in those organizations. Looking at the reward and recognition, this is a Mehtar Shield, which I started when I was at Tigerberg, and it is the most coveted shield there is. There's that very, very proud colleague of mine from running the respiratory intensive care unit. We do an audit in August of all aspects of infection prevention, and everybody around makes sure that they get the best out of it. And at the end of the day, those that do exceptionally well, and there are 4 independent people that do the audit and the marks, they then come together at the Hartman lecture and they give this prize. And there are 2 runners-up, and these are then displayed. On the other side are the link nurses that are celebrated, and we always do a very big function for them at the end of the year, just to say thank you for being who they are. Okay. The IPC notice board is a visible reminder for the linked nurse program, but also for others. It's all the relevant information goes on now. The clinical staff can monitor their own performance. The audits go onto it. The annual audit, the HI audits go on it. The hand hygiene audits go on it. The quarterly statistics. Everything is on there, including a little bit of education, which is the micro. And this is the quarterly alert thing. It tells you. We ran it from the infection control unit. This is the audit checklist. This is what you guys did. Yes, you did really well. No, you didn't do well. Yeah. And of course, the other thing was the infection control manual that we had. We put it on the iDrive, and it was available to them anytime they wanted. Not that they used it very often. Mind, they keep ringing us up, but that's okay too. This is something that I did because I had to show that they wanted to use our infection control team for general work, like would you mind, helping out in the outpatient department, or in the wound unit, or in here or there or whatever. So we did a costing, and I did this because I wanted to show them what was going on. So if we're looking at a nurse, full-time infection control practitioner, which is really 38.5 hours, they spend 25% of their time in meetings. They spent 30% of their time in a high care ward, which was 169 beds and 12 hours a week, which came out to 4.7 minutes, less than 5 minutes per bed, should they be needed. In the general wards, they spent 3.4 minutes, less than 4 minutes per bed, should they be needed. Okay. So at the end of the day, it was really interesting that they only spent about 43% of their time doing clinical work. They spent time doing lab, they were doing the admin, they were writing reports and so on. But what's really interesting to me was the fact that they were considered, we would like to see infection control practitioners and specialists as being clinicians, as being clinically involved, but they spend most of their time not being clinically involved. And what I was trying to prove to them was that, please, can we not be doing all this other stuff that's going on around them? So there were overlapping duties, like the visits to the units. They spent 9 hours a week going to the various units, which worked out a lot more. But this didn't cover an outbreak response, which is a completely different situation. So looking at a cost of intensive care unit, I want to bring you back to this because this is how we managed to get the best sterile services department in Africa at Tygerberg Hospital. We looked at the cost of infection of an ICU bed, which was $1,300, let's say $1,400 US dollars, and looked at the COVID cost as well. So I don't want to go into all the others because they're a lot higher. This was when we started the program. So we started looking at an overall infection rate, nothing specific, just an overall infection rate in the intensive care unit. We started with the infection control practitioners here, and we looked at a reduction, okay, which came to the first year, it was 31 cases, that was all. It is a very, very crude way of looking at it. The second time we set up the audit and the report, we reduced by 154 when we started doing the audit and the surveillance, plus education and support, to consider it an intervention. Then in 2009, I had to go off to write a book. And one of my IPC colleagues got pregnant. And so we were left with only one infection control practitioner at this 1,300-bedded hospital. And surprise, surprise, we had more infections in the intensive care unit. It went up by 47. We all came back, obviously, and then we came, the team of 4 IPCs, including myself, and we managed to reduce it by 171. So here we then went with this data to our CEO, and we showed them what the cost would be. And we said we have saved probably between 9 to 17 million. Can we please have 3 million for a sterile services department? And he said, yes, you can. So we got that money, which we then set up one of the most state-of-the-art sterile services department. The other thing that we did was we looked at the rationalization of gloves. Okay, this is the usage of the gloves, and the second year we introduced a policy between 2005 and 6 and looked at what happened there and the difference of the usage as numbers. Then we put money to this thing, and at the end of the day, we managed to save almost R1 million. And those days, R1 million was actually quite good. And again, we had that money, half of it anyway, available to us to set up training programs for the linked nurses. So we could get some of the money back. And I think I should be on my way to stopping now with this. I just want to summarize some of these things. So some aspects of lack of implementation are very similar, like the behavior, the clinical dependence, and lack of accountability and so on. But there is a lot one can do even without the money. There is a lot one can do. Okay. In low to middle income countries, we are really battling with infrastructure issues. We have difficulty with appointing new staff. We have difficulty in investing in infection control programs. But those that we do have, we have managed through various organizations, including the national the national societies, to try, and also ICANN has been very instrumental in setting up and moving forward with infection control programs. They don't all have to do all the core components. They don't all have to do all the minimum requirements. They just have to do something. They just have to start somewhere. And of course, as you remember, I just want to remind you that this investment is probably the best investment one can make. And my conversation with the folks that set up the National Insurance Health Program in South Africa is that they need to really emphasize on infection control if they want to make sure that they have enough money and that the infection rates are low. So on that score, I would like to say thank you and hand back to Martin, please.
Well, thank you so much, Shaheen. That's a really nice summary of all your years of experience and how you can help other people learn from where you've come from and what you've managed to achieve. You mentioned I might have some comment about education and it all being samey. Interestingly, I gave a talk last year about infection prevention education, and I asked people to put in one word about their experience of infection prevention education. And the words I got were repetitive, frustrating, boring, samey, uninspiring, all the same, one way, laborious.
Yeah.
But unfortunately, these are the words of the people who actually are delivering the training and not the recipients. So I think you're right. We aren't taught to teach well. And when I started back in infection prevention in 1990, I pretty quickly worked out that I don't do infection prevention. Everybody else does it. And I'm there to sort of help and cajole and support and try and educate. So I tried to use as much local data to make it real to people as possible. Is that something that people should be considering to make their sessions directly applicable rather than just going through this exactly the same technique on hand hygiene again? Because we need to go about it in a better way to get engagement, don't we?
Absolutely. I mean, we do that. This is why when we do our teaching, a third of the time is spent for the peers, the students, to go and take videos in their hospitals and come back and talk about them amongst themselves and with us. So they show us, and we say, today we're going to talk about, let's say, sterile services department. They take a 5-minute video of their sterile services department, bring it in, and then they sit and talk about it. So that's a very different way of teaching, which I think is very effective because they remember that much better than, as you quite rightly point out, this very laborious, boring way of going through systems. So I agree with you on that totally, yes.
Yeah, and I always think people should enjoy the training as much as possible as well, because to my experience is if you enjoy something, if you can make it fun at all, people are much more likely to remember it. There we are. Now, you mentioned, you talked a lot about the cost. Have there been any really good cost effectiveness studies? I know you've done your sterile services work to actually get the best department. Did that get written up, or are there some really good cost effectiveness studies? Because it's all very well saying, yes, it's going to save money, but we don't necessarily persuade hospital chief execs and policymakers with these data. How can we produce something that they would sit up and actually say, okay, if I'm going to take a leap of faith here and employ a group more people to actually help with a good surveillance program so we get better data and save money for the organization, how can we do that?
Yes, I think that's a really important point, and I'm as remiss as anybody else for not writing it up. I'm terrible in the fact that I love to look for things. I find things and I get very excited about it, and then I don't write it up. You're quite right. So I think at the end of the day, we should have written it up. But maybe we can still write it up. It's not that long ago. And I
can't see why not. It's still going to be relevant, isn't it? It's still going to be relevant.
Yes. No, thank you, Martin. I think that's quite important that we think about what, because we only hear about disasters. We never hear about success stories. And I think we should.
Yeah.
And I think you're absolutely right. We should do that.
I think you hit the nail on the head there. We sort out a disaster, and then we move on, and we move on, and we try, and we don't tell people, actually, we tried that and it didn't work, or these things did not work, but then this did work.
Yeah.
And I think that would make a very big difference to us.
Hmm.
Okay, Shaheen, I'd just like to highlight everybody else what the upcoming lectures are on the Weber training webinars for the rest of the year, the teleclasses. We've got a very action-packed September with a number from the Afro-European teleclasses, looking at antimicrobial resistance, resource sustainability, food safety. We have a number of sessions also coming from the IPS conference, which is going to be held in Brighton at the end of September as well. October also, we have some excellent sessions, including talking about community C. diff with Professor Thomas Riley from Australia. We have our usual special lecture for Clean Hospitals Day with Didier Pite as well. John Otter and Curtis Donsky are going to be talking to us later on in October, as well as is Georgia Gon from the London School of Tropical Medicine. So plenty to look forward to for the rest of the year for the Weber teleclass sessions. And if I can just highlight our thanks to our teleclass education patron sponsors who make teleclass education possible. That's Diversi, Virox Technologies, and Gamma Healthcare. And finally, just again, thank you to you, Shaheen. It's always great to hear your voice, and you're clearly on fine form. So thank you very much for sharing your expertise and experience with us today.
Thank you.